In order for a patient to have anticholinergic toxicity, they have to be exposed to something with anticholinergic properties. Well, you'd be surprised at how many common medications have anticholinergic effects to them. Some of these include antihistamines, antipsychotics, antidepressants, muscle relaxants, and one that commonly pops up on exams is Jimson weed. There are also a couple miscellaneous medications that contain anticholinergic effects as well. As you can see, some of these medications are fairly common. You can imagine if a patient has already taken one or two of these medications and then a third one is prescribed to them, or they decide to take a medication over the counter such as diphenhydramine, these anticholinergic effects can build up and it can lead to anticholinergic toxicity. There's a really simple way to remember all the symptoms that come with anticholinergic toxicity. You can use the saying mad as a hatter, which is altered mental status, hot as a hare, which helps you remember hyperthermia, dry as a bone, which is dry mucous membranes, absence of sweating or anhidrosis, and urinary retention, red as a beet, which will help you remember flushed skin, and blind as a bat, which is mydriasis or dilated pupils. So now let's talk about how these symptoms occur. In order to better understand anticholinergic toxicity, we have to talk about the autonomic nervous system. Now there is a previous EasyMed video on the autonomic nervous system, which I'll link above, so we're not going to go into too much detail. But remember that there's the sympathetic nervous system and the parasympathetic nervous system. They're both constantly functioning, but they essentially counteract one another. They're basically opposites. The sympathetic nervous system produces the fight or flight response. It uses catecholamines such as norepinephrine and epinephrine that bind to adrenergic receptors on target tissues and organs, and this produces that fight or flight response. So it's going to upregulate critical actions that are necessary for immediate survival, and this will include increasing heart rate, opening the airways, and dilating the pupils. On the flip side, it's going to downregulate those actions that are not necessary for immediate survival, and this includes salivation, digestion, and urination. The parasympathetic nervous system is involved in the rest and digest state. It uses acetylcholine that binds to cholinergic muscarinic receptors on target tissues and organs. And what this does is it increases the function of those non-critical actions, and that's why it gets its name rest and digest. So it's going to increase salivation, lacrimation, digestion, and urination, while downregulating or normalizing those critical actions. So this will include constricting the pupils, bronchoconstriction, and decreasing and normalizing the heart rate. So where does anticholinergic toxicity come into play? Well, we just said that the parasympathetic nervous system uses acetylcholine that binds to cholinergic muscarinic receptors on target tissues and organs. When we take medications that have anticholinergic effects to it, it's going to block those cholinergic muscarinic receptors and essentially wipe out the parasympathetic nervous system. So look at what we have now. We have an unopposed sympathetic nervous system that can function normal, and we've wiped out the parasympathetic nervous system that would normally regulate it. And that's why a lot of the symptoms of anticholinergic toxicity mimic sympathetic surge. So you're going to have a fast heart rate, dilated pupils, decreased salivation, urinary retention, decreased digestion. And the reason behind this is because you not only have a functioning sympathetic nervous system, but it's unopposed because we've wiped out that parasympathetic nervous system. So as we said before, anticholinergic toxicity can look a lot like sympathomimetic toxicity. There are two key differences, however. The first one involves the pupils. So we know that the sympathetic nervous system dilates the pupils, and the parasympathetic nervous system constricts the pupils. Well, with anticholinergic toxicity, we know that we wipe out the parasympathetic nervous system. So rather than the pupils being constricted, they're going to be dilated because we have that unopposed sympathetic nervous system. So here's how you can tell between the two because they're both going to have dilated pupils. It involves shining a light in the patient's eyes. In a patient with sympathomimetic toxicity or sympathetic surge from, let's say, cocaine or stimulants, when you shine a light in their eyes, their pupils are going to constrict because they still have their parasympathetic nervous system functioning to allow for constriction to occur. On the flip side, with anticholinergic toxicity, their pupils are going to be dilated, but when you shine that light in their eyes, their pupils are not going to constrict, and that's because we've wiped out and blocked that parasympathetic nervous system. The second way to tell the difference between the two is to look at the patient's skin, and the reason for this is because sweat glands have cholinergic receptors on them. However, they're unique because they're still innervated by the sympathetic nervous system. Remember that the sympathetic nervous system normally uses norepinephrine and epinephrine that bind to adrenergic receptors. The sweat glands are an exception because their sympathetic innervation releases acetylcholine onto cholinergic receptors of sweat glands. There is not much parasympathetic innervation onto sweat glands. So here's what's unique. With anticholinergic toxicity, remember we've wiped out the parasympathetic nervous system. This would normally leave unopposed sympathetic activity. So you would think the patient would have a lot of sweating. Well, remember that sweat glands have cholinergic receptors on them. In anticholinergic toxicity, we have now blocked and wiped out those cholinergic sweat glands. So even though there's unopposed sympathetic activity, there's not going to be any sweating. And that's the key difference. Someone with anticholinergic toxicity is going to have decreased sweating called anhidrosis, versus someone with sympathomimetic toxicity from cocaine or stimulants, they're going to be very diaphoretic. And the reason for this is because in those patients, their cholinergic receptors on their sweat glands are not blocked. So their increased sympathetic activity will lead to increased sweating. So now we have talked about most of the symptoms with anticholinergic toxicity, except for two of them. The first one is altered mental status. The central nervous system, specifically the brain, has muscarinic receptors that are involved with attention and cognitive functioning. So you can imagine if we block those receptors in anticholinergic toxicity, it can lead to confusion and altered mental status. The other sign or symptom is flushed skin, and this is a result of CNS temperature dysregulation, as well as that absence of sweating doesn't allow for heat loss. So now that we understand the symptoms of anticholinergic toxicity, let's briefly talk about how to work up the patient that presents with altered mental status, a fever, and fast heart rate called tachycardia. Obviously, infection is going to be on your mind, and that's going to include encephalitis, UTIs, sepsis, meningitis, and pneumonia, just to name a few. Well, it's important not to go in tunnel vision, automatically assuming that this is infection. Things like medications, side effects, psychological issues, or toxidromes can lead to similar presentations. And some of these include serotonin syndrome, thyroid storm, withdrawal, malignant hyperthermia, sympathomimetics, heat stroke, drug toxicity, TTP, and neuroleptic malignant syndrome, just to give a few examples. So let's talk about how to broadly work up these patients. As we stated before, infectious causes are going to be on your differential. So some consideration tests could be a complete blood cell count, chemistries, liver function tests, a urinalysis with urine culture, blood cultures, and a lactate. However, it's important to consider those non-infectious causes as well, and you may also consider ordering a drug screen, thyroid studies, ethanol salicylate, acetaminophen, and ammonia levels, as well as a pregnancy test. Some other things to consider include a blood gas or EKG. You may also consider getting imaging. A CT head could be used to look at both infectious or non-infectious causes. For example, you could be looking for signs of a brain abscess versus a head bleed. You may also consider getting a chest x-ray to look for signs of pneumonia or other causes. Lastly, procedures may be necessary, and this could include lumbar puncture if you're worried about meningitis, or maybe the patient has a history of hepatic cirrhosis and they're presenting with altered mental status, ascites in their abdomen, as well as abdominal pain, at which point you might be worried about spontaneous bacterial peritonitis and you have to perform a paracentesis. So the takeaway point is that there's a lot of things that can cause altered mental status, fever, and tachycardia. So you don't want to tunnel in on one diagnosis too soon. It's important to keep a broad differential and work it up appropriately. Let's wrap this up by talking about the management. It's important to involve a toxicologist or local poison control center if you can. They can provide a lot of guidance. If the patient intentionally tried to overdose or inappropriately took anticholinergic medications, or you need to involve psychiatry for any other reason, make sure that you do so. The initial approach for management is going to involve supportive care. If the patient has any mild or moderate delirium or agitation, it's important to make sure that the room is quiet, dim the lights down, and if family members are present, make sure that they're in the room because they can help provide support and reassurance. It's also important to use verbal de-escalation before jumping to physical or chemical restraints if you can. If the patient is hyperthermic, you can try antipyretics, cooling measures, or IV fluids. Unfortunately, these don't always work though. In some circumstances, medications may be required. If the patient presents within 2 hours of ingestion, the GI decontamination could be considered using activated charcoal. It's good to do this in consultation with the toxicologist. Benzodiazepines may also be necessary for delirium and agitation refractory to verbal de-escalation, seizures, and prevention of hyperthermia and injury from rhabdomyolysis. If you notice that the patient has any conduction abnormalities or widened QRS on EKG, then sodium bicarbonate can be considered. And the reason for this is it's possible that the patient had a co-ingestion of another agent. Maybe they ingested a TCA, which is known to widen that QRS, or maybe they ingested some kind of sodium blocker. Either way, sodium bicarbonate can help with those conduction abnormalities. Lastly, let's talk about the antidote. If the anticholinergic toxicity is so severe that it's leading to hemodynamic instability, life-threatening arrhythmias, or severe delirium, then physostigmine, which is the antidote, may be necessary. It's important to use this in consultation with the toxicologist. Physostigmine is an acetylcholinesterase inhibitor, so let's walk through this. Remember that we said parasympathetic neurons release acetylcholine onto cholinergic muscarinic receptors on target tissues and organs. and this produces that rest and digest response. In that synapse, there's an enzyme called acetylcholinesterase, and this enzyme binds to acetylcholine and breaks it down. Physostigmine is an acetylcholinesterase inhibitor, so it's going to bind to the enzyme and prevent it from breaking down acetylcholine. So this is ultimately going to increase the acetylcholine levels in the synapse, and it's going to help overcome the cholinergic blockade that's produced by anticholinergic toxicity.